So let's get a few definitions out of the way. The first is nutritional status. This is a measurement of the extent to which an individual's physiological needs for nutrients is being met. Nutrition assessment is the systematic approach used to collect, record, and interpret relevant data from patients, clients, family members, caregivers, and other individuals and groups. And then nutrition diagnosis is a diagnosis of the nutritional related problem. I'm really going to highlight this nutritional related problems, not necessarily just medical. So here we have nutrition screening or referrals. This isn't in our nutrition assessment because anyone can do this. I'm just going to put any. Could be a nurse, an MD, social worker, but they have screened and determined that this person should get a nutrition assessment. And this is where the RDN comes in. So after here, RDN. And so we have the assessment to the diagnosis to the intervention and monitoring and evaluation. So someone might get a screening or referral based on a diagnosis of diabetes, stress fracture, having over fat or excess adiposity. So we need to think about what factors influence nutritional status. Well, the optimal nutrition status is often thought of as a balance, where nutrient intake is on one side and nutrient requirements are on the other. But these aren't equally weighted because different things go into both sides. Let's start with the food intake and absorption. So food intake is the most obvious nutrient intake, but this can be affected by diseases, economics, behavior, emotions, and cultural pressures. Some diseases that could affect food intake could be if someone is in treatment for cancer and on chemotherapy, they may have lower food intake because the chemotherapy makes them feel sick. For economics, it could be something like the person doesn't have enough money to have adequate nutrient intake. Behavior could be they maybe are not eating enough because they're trying to lose weight, or maybe they're eating too much. Emotions, of course, I always like to joke that after you've been broken up with, you never find yourself in the produce section, but you often find yourself in the ice cream section. So our emotions can influence what foods we're taking in. And then cultural pressures. So in some cultures, eating bugs is common and it is an acceptable cultural practice. In the US, eating bugs is not as much as of an accepted cultural practice. People would look at that person odd. Then we have absorption. So think about someone having type 2 diabetes. If it's poorly controlled, insulin is not signaling for nutrients to get into the cells. So that means that the nutrients that are consumed are not being absorbed. Similarly, it could be someone with, say, celiac disease. A person's nutritional requirements are also based on a variety of aspects. Infection, disease, fever, physiological stress, these will all often increase nutrient requirements, as will growth. Things like physiological stress can also increase nutrient requirements, but also can increase fat deposition. And then we need a certain amount just for body maintenance and well-being. So the nutrition assessment is a comprehensive approach carried out by a registered dietitian to determine nutrition status. To provide patients and clients with optimal care, dietitians must go below the surface and think like an investigator. RDs are nutritional status investigators. Critical thinking is the most important skill that we can use. Oops, sorry. I'm supposed to just want to highlight, but it let me just highlight that critical thinking is the most important skill as an RDN. And that's what this class is going to be testing, critical thinking. So you will need to memorize things, but you'll need to memorize them in order to actively use them in critical thinking, not just to memorize them. So our goals are to reduce disease risk, identify patients who require aggressive nutrition support, restore and maintain current nutritional status, identify appropriate medical nutrition therapy, monitor current status, and also evaluate and audit quality of care, assess and demonstrate cost effectiveness, so we have the ABCDs of assessment. A, obviously, anthropometrics. Next, biochemical or laboratory, clinical or physical, dietary, environmental, and finally social. All of these pieces are needed to determine the diagnosis. However, not each diagnosis will rely on each one of them, but having this information is helpful. So let's think about anemia. Oof. For anemia, we will probably have some biochemical or laboratory, things like iron, maybe B12, but we'll also have clinical and physical, pale gums, maybe general pallor. From these two, we can start to assume that it is an anemia, and then it's a good job to get dietary to see, are they eating meat? Is it a meat related or an iron related anemia? Maybe it is B12 related. If it's B12 related, you may also want to check if they're a vegan. If they're not a vegan and it doesn't seem to be B12 related, it could be environmental if they have, say, lead poisoning. So this is just an example to highlight how each part of these can go into a simple diagnosis like anemia. So when we are assessing our patients and giving them treatment, we need to use what's called evidence-based medicine. And evidence-based medicine is important because for a long time, clinicians really relied solely on this first, clinical expertise. And this isn't to say that clinical expertise isn't useful or important. It is, but as science progresses, and especially medical science, we find new treatments that relying simply on clinical expertise may miss. So we also need the best external evidence. So with these two, we also need to take into account patient values and expectations. Ooh, that was a rough underline. But let's go back to our anemia. If the person has anemia due to iron deficiency, and you as the dietitian suggest eating more red meat, but our patient practices Hinduism, we aren't going to be able to address their problems because individuals who practice Hinduism don't eat red meat. Well, they don't eat beef. They may eat other meats. So we also need to use some basic tools. We should look at their medical diagnosis. And again, remember, this is not the nutrition diagnosis. And DX stands for diagnosis. A medical diagnosis could be something like, say, lung cancer. People generally don't get lung cancer from anything that they can eat, but that doesn't mean that someone with lung cancer might not also have a nutritional diagnosis. We can look at their medical chart. So let's say we are dealing with someone who has lung cancer. Some things that would be important in their chart: are they on chemo? What stage? Do we have a physician's note, a nurse's note, other healthcare practitioner? Do we know, or have they lost weight? Also, the medical referral. So if your patient who has lung cancer is referred to you, looking at the medical referral will probably give you a specific. Maybe they specifically are being referred because they've lost weight. And also their surgical history. So did they just have some sort of surgery? Maybe they had lymph nodes removed. That's going to change what they can eat. And we also need to look at their drug history. So drugs like opioids will decrease appetite. So that might be related to weight loss. All right, before we move on, we have to take a brief sidebar into standards and statistics. Standards are what are needed to compare what is quote unquote normal versus pathological. Standards provide a population-based set of reference values. So these are standards that work best for the entire population, not necessarily an individual. Now this gets tricky because very rarely are we assessing a population. We're usually interacting with an individual. So some of the standards we used are things like the recommended daily intakes, BMI cutoffs, red blood cell counts. But not all of our measures have standards. Think about body fat. It's also important that we take a minute to think about what we mean when we use this word, normal. In something like red blood cell counts, normal doesn't really have a valence. It doesn't have a connotation. But when we talk about normal body weight or normal BMI, then we do get into an issue where that has a connotation. So to avoid conflation, it's best to avoid the word normal. So let's just cross that out. And instead use something like a reference value, or another term would be healthy range, but even that has a little bit of a connotation, or reference or recommended. So we have a ton of standards. I don't expect you to know all of these by heart. And in fact, we're going to do a couple of notebook projects that will help you just quickly look up standards. But it's helpful to look at the bell curve when we think about standards. So this is a bell curve for just any nutrient. And so we see this is percent of the population and the level of requirement. So how much? So the average, if we're on a true bell curve, this is what most people need. This is the amount needed to satisfy the most people. To keep the most people healthy. So the average is great. As we can see, it has the peak is at the maximum of the population. However, not everyone is on the average. You'll notice that some people are 2 standard deviations below, 2 standard deviations above, and even more. Technically, this line goes out infinitely without ever hitting zero, potentially. The problem is we can never actually test the entire population, so we need to test a representative sample. A representative sample needs to, like it sounds, represent the population. So it should have the same demographics as the entire population. Unfortunately, not a lot of our RDAs and other standards were tested with a representative population. Okay, so let's think again. Oh, here, I'll need to erase this. Maybe let's erase this part now so that we can see. Most people have heard of a standard deviation, but even scientists tend to forget what a standard deviation means. So this is the measured value, xi. This is what we're actually measuring. X bar is the sample mean. This is X bar. We then have, so we're saying for every, for us, N is person. So for each person, from 1 to however many we have, take the measured value of that person and subtract the sample mean and square it. And then you take that and you divide it by the number of people minus 1, and you take the square root of that. You don't need to worry too much about this part. You don't even need to worry as much about what the mean is or the value. The most important part of this equation is the sample size. You can play around with this on your own, but the smaller the sample size, the bigger the standard deviation will be. And we know that because we're dividing by it. So the bigger this number is, n, the smaller the standard deviation. Let's just remember that. Big N, small standard deviation. So let's go back to our bell curve. Now if we look over here, let's say that this nutrient is iron again. So most people will need X bar amount of iron, but some people will need much more, 2 standard deviations above the mean. Other people you'll meet will need much less iron. So we always have to keep in the back of our minds that we have a population mean, but individuals may need less or more. So let's apply these statistics. First, we have sensitivity. This is the ability to detect a person with a disease. If a person has a disease, how often will the test be positive? So I like to think about these in terms of pregnancy tests. So if we have a little lady, and she takes a pregnancy test and she is pregnant, so we're going to put a little circle inside her, the test should be positive. If it is a negative, if the pregnancy test says, oh, you're not pregnant, but you really are, that test has bad sensitivity because it's unable to detect a person with the thing we're testing. Here we say disease, but it could be a baby. So this is good sensitivity. Sensitivity. Might have spelled that wrong. Bad sensitivity would be if you have your pregnant lady but the test says that it's negative. We also have specificity. And this is the ability to detect people without a disease or a problem. Apologies for that. So let's then think of it the other way. If we have good specificity, that means this lady's now not pregnant. This is a different lady who's checking if she's pregnant. Not pregnant. It should be negative. That's good specificity. Bad specificity is if you were to take a pregnancy test and you're not pregnant, but it says you're pregnant. That's bad specificity. So another way of looking at this is, does the person have the condition? So this is saying they have whatever it is. Let's say this is pregnancy. So this would be the person is pregnant. If the pregnancy test set is positive, preg test, then we have a true positive. Even if that lady doesn't want to be pregnant, it's good that she got a true positive because now the test is sensitive. If the person gets a false or gets a negative, it's a false negative. The person really is pregnant, but the test is saying it's negative. But then we have people who do not have the condition, not pregnant. But they are going to take the same test. If the person is not pregnant, but the test says they're pregnant, that's a false positive. If a person is not pregnant and their pregnancy test is negative, that's a true negative. So again, this is specificity. Specificity is if the person doesn't have it. Sensitivity is if the person does have it, whatever it is. Sensitivity is also equivalent to statistical power, where specificity is the same as the p-value. We can also think about the positive predictive value, which is the probability that the subject has the disease given the test is positive. So for this, what you can think of is maybe you have 50 women and they all are taking a pregnancy test. We know that only 10 are pregnant, which means 40 are not pregnant. If we had perfect positive predictive value, the tests would show 10 people positive and 40 people negative. However, very rarely do we have a test that is perfect. So more likely, might be something like 11 people test positive and 39 people test negative. In that case, this has a slightly lower positive predictive value because it has accidentally grouped one person who isn't pregnant as being pregnant. If the prevalence of the disease is very low, a positive test is likely to be a false positive, even if the test has excellent sensitivity. And this comes back to our sample size. So again, with our 50 women, 10 of whom are pregnant, 40 are not pregnant, this is a pretty small sample size. So The test will probably overinflate how many pregnant women there are. It will have false positives. So again, we said 11 last time. Let's increase it to 15, which means 5 false positive. And then that would mean we have 35 who are not pregnant. And we don't have any false negatives. So this, you're more likely to have this occur if you have a small sample size. But if you have a very large sample size, the more measurements you take, the more accurate we get. Okay, now we're out of our little statistics. Let's get into the meat of anthropometrics. The basic definition of an anthropometric is a physical measurement. So it could be a physical measurement of anything, arm length, foot length. Mostly what we're doing though are things like height and weight. And we need to compare those to standards. Or we need to compare them to the patient's own anthropometric history. These measurements become more valuable over time because it's more informative if we have a patient's measurements over time, even compared to standards. Getting good anthropometrics, though, requires skill. It's estimated people need to practice greater than 20 times. That's why we have a lab. Smiley face. So although we don't have great standards for anthropometrics, we do have standard ways of measuring them. And this is from the National Health and Nutrition Examination Study, or NHANES. They use 2 professionals to examine and record anthropometrics. The examiner performs all measures. They position the participant, and they tell the recorder the measured value. We only want one examiner because this is going to minimize measurement error. So decrease measurement error. The recorder enters the measured value, checks that it's within a reasonable range, and assists with the positioning of the patient or participant. Checking that it's within a reasonable range is important, especially when measuring height. The examiner might accidentally read off the centimeters. They may say, this person is 24 centimeters tall. That's very short. In reality, they might have actually meant 24 inches. And if this is a small child, that's around 2 feet. That makes sense. So the recorder would say, hey, do you mean 24 centimeters or 24 inches? So as we age, we need to use different anthropometrics. When we're very young, we use a lot of different ones. But once we get to about 8 years old, these are about the same as adult. So we use these anthropometrics and we create indices, and the most famous being body mass index, or BMI. It's the most widely and commonly used standardization of body mass, not weight. Let's just highlight that. Not weight. So BMI is a person's mass in kilograms, and let's also highlight the units, divided by a person's height in meters squared. The units matter. If you are measuring in something other than kilograms, say pounds, you need to make sure you use inches. Maybe your measurement is in centimeters. You need to convert to meters. So I expect everyone to know this table by heart, but basically what we have here is the cutoff points for BMI for adults between the WHO and NHLBI or the CDC. You see they're primarily the same, although the category for overweight is slightly different. This is called pre-obese. And we'll get to why they might use that term. So BMI has gotten a pretty bad rap lately. So why do we use it? Well, it's easy and it's inexpensive. It shows a good correlation with adiposity, and it's a useful predictor of future mortality and morbidity. This is the biggest reason. Even though it has its flaws, at the population level, BMI is a useful predictor of a disease state or the chance of getting a disease, and a good predictor of death. It's also non-invasive and requires minimal training. The cons, it includes all mass, not just fat mass. So it may be masking sarcopenic obesity, which is a loss of muscle mass resulting in excess fat mass. So loss of muscle. There's also differences in sex and ethnicity. Sorry about that, I'm drawing all over the screen. So we know there's differences in sex and ethnicity, and we'll take a look at East Asian populations and men versus women. So if you've taken weight control from me, you know that I have some qualms with trying to predict ideal body weight from just a person's height. So that's what Hamway and Mifflin St. Jour use to predict ideal body weight. And it gives a single value. But especially for someone with obesity, their single value may be nearly unobtainable for them. That's why I like the Peterson method. With the Peterson method, you enter an ideal BMI. And this is nice because we have a range of ideal BMIs. You should know these, but it's from around 19 or greater than 18.5 to around 24.9. That gives us a wide range of body weights a person can be. But even if the recommended BMI isn't a good fit, maybe the person has very severe obesity, we can choose another more manageable BMI and get an ideal body weight. Now, this gets tricky in children and adolescents. Body weight is not consistently related to body fat during childhood, and body composition changes with age and maturation. Adolescents of the same age may differ substantially in maturation. Think about in high school, I think it's most obvious in the boys, but there'll be some boys who look like they're still little kids. And there'll be some boys in the exact same grade, exact same age, who are growing facial hair. So even though they're the same age, they're different maturation status. So we want to also define obesity based on a health risk. For adults, we have morbidity and mortality, but this is tough in kids because we have to follow them for a long time to find out if they develop a disease or death. So we have a lack of long-term follow-up data. So to try to correct this, we use growth charts. Growth charts have age on the x-axis and the anthropometric, in this case, BMI of interest, on the y-axis. And here, we would calculate the BMI for a girl between 2 and 20 years. So let's say the girl is 9 years old. Let me see if I can zoom in. Yeah, a little bit. So we have a 9-year-old girl, and she has a BMI of, let's say, 22. 22 for an adult is in the recommended range. 22. Oops. But is it recommended for a 9-year-old? Well, that's where we would then look at our growth chart. So we would go down to 9 years old, which is down here, where I underlined. And then we would take a line, and it's hard to do, but we would go all the way up to 22, which is right about here. Let's see if I can. So right where that red dot is, and we then look, okay, what line is under it? That's the 95th percentile. So a 9-year-old with a BMI of 22, although it's recommended for an adult, for a 9-year-old girl, this is an obese BMI. So BMI percentiles are often used. The percentiles are based on populations before the epidemic of obesity. And they use these befores as a standardization technique. So the data for that are based on data from 1960 to 1994. The problem, though, is that the percentile values don't reflect the current population status. There's also a ceiling effect. We can't go over 100%. We can't have more than 100%. So even if someone is gaining weight, we have this problem where we can never reach 100. So then we just infinitely get smaller and smaller and smaller. So this would be like 99.999998. It's tough to know what the difference between 99.999998 and 99.9977. But this could be a large amount of weight. It just looks small in terms of the percentages. This is called a ceiling effect. And it's called that because you can think of 100% as being a ceiling that we can never touch. So, to try to correct for this, we have a BMI Z-score. And a BMI Z-score is the number of standard deviations above or below the mean. So recall our bell curve. This is the mean. We're just going to say it's 0. There's one standard dev. And that would be negative. And we have one standard dev positive. And we can keep going infinitely. This could be 100 standard deviations from the mean. So we don't have a ceiling effect, but it's difficult for lay to interpret standard deviations. Also, we don't have any cutoffs. So unlike percentiles where we have the 85th and the 95th percentile to determine overweight and obesity, there's no cutoff because it depends on what population we're using. But if you are doing statistics, there are packages out there that will help you with that. So I do expect that you memorize this table. You should know that a child who is underweight is less than the 5th percentile. A recommended weight, I keep meaning to change these slides to recommended, but always forget. So let's say recommended. Overweight is the 85th to the 95th percentile. Obesity is the 95th percentile. And here we have our ceiling effect, where severe obesity is greater than 120% of the 95th percentile. So again, let's think about, this is 100%, and this will be 95. If we're creeping up there, we're never going to hit 100. We can't have 100%. But we can zoom in on what's above the 95th percentile then, and say 95 to 100. And we could then say, okay, within here, we can get closer and closer, where this is 120% of 95. So what is 120% of 95? Pull out a calculator and do that really quick. So 120%, we can think of that as 1.2 times 95. That's 11 and 2/5. So then it is creeping up. So this would still put us above 100% at 114, but it's a way of describing it without going over 100. So this would still be 114%. Like I said, the ceiling effect gets confusing. So now let's take a look at the difference between age and ethnicity. So here we just have girls, and they're 4 to 6 years old, 7 to 9 years old, and 10 to 20 years old. We also have 3 different ethnicities: Southeast Asian, Black African American, and White European. So if we just look at the 25th, or at a BMI of 25 across the board, we can see that for the African American girls, they have less body fat compared to Caucasian girls at the same BMI. So who is at more risk here? The white European girls or the Black African American girls? In this case, the white European girls are at increased risk at a body mass of 25, where the Black African American girls are at a decreased risk. Another way we could look at this is we can see that the African American girls, let's say they have a fat mass index of around 5.5 at a BMI of 25. We can then go up to where the white European girls are, and we see that this is equivalent to a BMI of about 23 for the white girls. Similarly, we can look at a higher age, and here we see that Southeast Asian girls have high body fat at the same BMI. So they're at increased risk. In fact, we can also look at a difference in age. So for the Black African American girls, a BMI of 25 is now associated with around, let's say 3.8. And then if we look at 10 to 12, it's around 3. So the fat mass at this body mass index decreases with age, and it also changes based on ethnicity. So based on this work, certain professors and researchers have suggested a different cutoff for Asian Americans because they appear to be at a higher risk at lower BMIs. Higher risk at lower BMIs. So they proposed that the recommended weight would cut off at 22.9, overweight would be at 23, and obesity would be at 27. So why do we even care about these ranges? Well, epidemiological or population-based show an interesting J curve. So if we look here at 18.5 and below 18.5, ooh, that line got a little crazy. Here we see increased risk of death. Now let's look, okay, it actually, risk of death decreases down to when we're in the 20s, 24, it's even pretty low at 25, 25 to 27. Then something starts to happen at around 29. We see that it's been relatively flat here, but now it's going back up. So we see that there's two risk areas, high BMIs and low BMIs, where the middle is recommended. But I want to draw your attention that these BMIs are technically overweight. So why do we even have an overweight category? The overweight category is not telling us about the relative risk of death, but it's telling us about the risk of becoming obese. So people in this category down here are more likely to become obese and then become high risk. We also know that for the same BMI, percent body fat is higher among women than men. So at each one of these BMIs, if we go up, on average, the women will be higher than the men. And this is because women need more fat on their bodies to maintain reproductive success. And we're going to come back to that over and over. But we also know that we lose muscle as we age, decrease muscle mass. With age. So for the same BMI, percent body fat is higher among older adults compared to younger adults. So to summarize, is BMI a measure of body fat? No. But it is a great screening tool. It's correlated with body fat at the population level, not the individual. And it's associated with cardiovascular and disease risk and mortality. That's the most important. So as I mentioned, BMI isn't perfect. And in fact, usually there's someone who is like a big weightlifter or something will tell me, oh, I have a BMI of 25, but I'm 5% fat mass. Well, that's awesome for them, but it's very rare on the population level. But one way that we can improve our BMI measurements is by taking into account waist circumference. So here we have a body shape index, or the ABSI. And the ABSI takes waist circumference, divides it by a multiplication of BMI and height. And so what this does is it takes into account waist circumference, which we know is a predictor of mortality and cardiovascular disease. So within each BMI category, a high ABSI was related to 30% higher risk of death compared to individuals with a low ABSI in the same category. But the highest risk of death was still in underweight and obese grade 2. So even though this gives us more information, it's actually telling us just about the same thing that normal BMI is telling us. People who are underweight and people who have more extreme levels of obesity are at the highest risk. But there is this nice fatcalc.com/ABS. This is fallen out of favor, but frame size used to be very popular. It's unclear the usefulness though. It appears to be related to cardiometabolic problems, but The results are mixed, and BMI appears to be a stronger predictor. So I'm just briefly going to touch on this because we won't measure head circumference. Head circumference is really important, but it's an indicator of non-nutritional abnormalities. Malnutrition has to be extremely severe. So technique is also important. So this is an anthropometric, but it's not one that we use. Let's look into our body composition metrics. So we can look at the body in different levels. You've probably heard that you're a walking bag of water. Well, kind of. You're a walking bag of water that's made up, that also has some lipids floating in it, and it also has some minerals, glycogen, protein, and a bunch of bacteria floating in it. So the two-compartment model has fat mass and fat-free mass. It doesn't tell the difference between minerals, glycogen, protein, and water. It's just non-fat. But we can get more compartmentalized. We can compartmentalize our adipose tissue into visceral versus subcutaneous. We can compartmentalize bone. We can also compartmentalize white adipose tissue versus brown or beige adipose tissue. So we have two types of measurements. We have reference methods or gold standards. These have the advantage of very high accuracy and reproducibility, but they often are very expensive and technically complex. Field methods are useful because they're low cost, they're often more simple, but they're indirect measures. So let's look at our gold standards. The goldest standard is hydrostatic weighing, and this gets at the two-compartment model. Oops, just want my, there we go. So it measures weight both in air and in water, like this happy guy. And then we use equations to estimate percent body fat. The problem, it's time consuming. You also have to have one of these pools, and these aren't that cheap to install. People generally are uncomfortable being completely submerged while trying to force all of the air out of their lungs, and no one really likes wearing a bathing suit. But hydrostatic weighing is based on the Archimedes principle of density equals mass divided by volume. So this is a principal law of physics and a fundamental to fluid mechanics, in which the upward buoyant force that is exerted on a body immersed in fluid, even if it's not fully, is equal to the weight of the fluid the body displaces. So let's think about a big glass with water, and we'll say this is 50 mils. If we put a 10-gram steel ball into this, it's going to displace the water. And in fact, it's going to displace the water by 10 grams. That is, it's immersed in the fluid, and the displaced fluid is equal to the weight. So it was at 50, now it'll be at 60 milliliters. And the displaced volume is equal to the weight of the ball, 10 grams. Which, lucky for us, the density of water is 1. And if it's mass, that means it's grams by volume. So we could have calculated it as, we know the density of water is 1 gram per 1 milliliter times 10 grams, which is the ball. We'd actually flip this, but since it's 1, it's still going to be 1, but let's just do that. So this will become milliliters over grams. Grams cancel out. We'll see a displacement of 10 milliliters. So again, density is mass divided by volume, grams, milligrams. milliliters. So we take someone's weight in the air, in grams, we'll say. We then get the weight in the air in grams and the weight in water in grams by the density of water, which we know is 1 gram per milliliter. And then we have minus the residual volume in milliliters. So let's do this. So grams minus grams. So we'll get the change in weight in grams divided by a gram per milliliter. So we can also describe that as gram per milliliter. Density of water is 1. So our grams cancel out. We get change in weight is now in milliliters. So now we can subtract residual volume, which is also in milliliters. So then we get weight in air, which is in grams, divided by the subtraction of the change in weight and residual volume in milliliters. And what do you know? Our units are density. So fat is less dense than water, bone and muscle more dense. So given a weight, fat will displace a larger volume of water and yield a greater buoyancy effect. We have to correct for lung and GI volume, but we have a pretty good standard estimate of error at around 2.7%. So the air displacement plethysmograph, or BODPOD, uses the same principles, but uses air displacement instead of water displacement. It has good estimates of percent body fat with good reliability, but you still have to be in bathing suits, even though you're not getting dunked underwater, which is a pro. It's also fast. It's around 10 minutes. But the errors can depend on how much clothing you have on and how much hair you have, because the air can't tell that your shirt is not part of your body. It can't tell that your hair is not part of your body. So the more clothes, more error. Increasingly, we can use imaging methods to quantify body fat, and these are very accurate. In fact, we can get visceral, subcutaneous, and even inner organ. So this is a study I did on toddlers, and here we have, this is the subcutaneous fat highlighted. In here, you can see this is the visceral fat highlighted, so these light colors. It has better resolution than CT, but it's difficult to obtain. In fact, this whole paper is about how I wasn't able to get good images in kids. And that's because it requires a breath hold, you have to be metal free, and even more than that, it's expensive. It's actually up to around $750 per hour.